opportunity to stretch a little bit and to explore some areas that I normally, on a day-to-day basis, don't get to talk to people about. So I just put some quotes up on the screen. I'm a great fan of David Allen. I don't know if some of you have read Getting Things Done. It's helped me over the years, and it helps me think about what I need to do next at any given time, and it tries to help me from a productivity standpoint to be focused and clear. We're all fallible. It's very hard, any of us in this world, dealing with all the different information streams that we receive. So let me start by defining terms. I've had conversations with others in the field, consultants, vendors, as well as my customers, and we often get hung up on what messaging is. And I'm going to stretch what I'm calling messaging a little bit. It's going to be the alarms and text messaging that's been talked about already, and I'm going to extend it a little bit further and include voice as part of all that. So voice was talked about a little bit earlier in regard to the ASCOM microphones and how that was part of that initiative. And in my world, voice plays an important part of the kinds of interactions that happen between caregivers, medical device systems, and patients and so forth. And whether from man or machine, these bursts of information are conveyors of status changes. They provide new details, signposts that there's something to be communicated, sometimes unnecessarily. So you've heard us talk, many of us, about alarm fatigue, and false notifications, and self-correction. Each message has varying degrees of criticality, running the spectrum of trivial, Facebook notification, to life or death. Somebody's in cardiac arrest. In the hospital context, I'll take a step further, bringing telephony into the mix, including mobile devices and all their permutations, text messaging, vibrations, and so forth. And altogether, it provides a kind of continuous wash of noise. And for the purposes of my presentation, let me telegraph my observations and point of view. We are being crippled under the weight of these messaging streams, and it's dangerous. Be it personally or professionally, few of us have the tools, the discipline, the constitution, or the training to manage these streams effectively. I was with my 82-year-old mother. She had me look at her phone. She had thousands of unread messages on her phone and an endless stream of notifications that were left over, in many cases, for weeks and months. And she doesn't know how to deal with it. And she's no different than the rest of us, whether it be the nursing supervisor at a community hospital, whether it be any of us in our day-to-day work, or the nurse manager, nursing supervisor, who's just simply unable to respond because of capacity issues, and more often than not, a faulty workflow that underlines that. These systems are just spitting out stuff, and for the most part, we're not paying enough attention to them. And while we might be tolerant or amused by this continuous state of half attention, when we're at the dinner table, watching the football game, in the movies, in a conference or a presentation, Snapchat, Facebook, Instagram, all of those things, not that healthcare providers are doing those things on their phone, but it's a constant drain on our attention. And it's not defensible when there's life or death involved. So whether it's a long-haul trucker who's going across the country in the middle of the night, whether it's a pilot, and the pilot was talked about earlier by one of our presenters, or a doctor or nurse. And I'm not suggesting that professionals are paying too much attention to their Twitter feeds in the workplace, and yes, that goes on. All of this is distracting, and it adds up, and we're all distracted, myself included. George, who's here, is going to present a little later. His boss is Maria Hale, and she once said to me, "I don't know what I don't know." And I'm thankful that she said that to me, because it made me realize how critical it was to find out ways to let her know about all the things that are flowing and traversing through her system. So I think we all know that the messaging deluge is going on, how much of it is going on, the impact of it, and the tools and techniques for taming it is an essential area that we, and I'm a technologist, owe it to our customers to develop, share, and collaborate on. So let me use my time today to explore that with you. So let's do a little audience participation. So I want you to all look at the screen, and I want you to think about it for a moment, and please, if you can, be honest. So on the left-hand side of the screen, and when I'm talking about messaging, anything that shows up on your phone, your desktop, computer, your laptop, whatever devices you carry, you have at home, your Amazon Echo Show, or whatever it is that may be. On the left-hand side of the spectrum, you're totally in control of that. You understand what's being fed to you. It's actionable to you or not. You're in control. And then on the right-hand side of the screen, you're getting bombarded at every possible moment in any given day, and you do not know which way to go, left, right, sideways, what have you. It's just noise to you. So anybody want to share? What's your number?
2.5.
Say again?
2.5.
All right, good. I suspect that you're on that side. But somebody else? You're a 3. Have any 5s in the group? All right, you're a 5. How about one more?
6.
Okay, good. So I will tell you that I'm a 2. But I will tell you that being a 2 requires a lot of work. It requires, I don't know, 2006 or so, there was a lot of publicity about something called inbox 0, right? So I try to have a tidy inbox, and if you look at my inbox on any given day, maybe there's 10 or 15 leftover messages. But in order to get to that, and I'm not trying to tell you how great I am, but I'm just telling you that in order to do that, to have some clarity, it takes a lot of work. So keep that in the back of your brain. And one of the things that I've really learned over the last 15 years is that caregivers, nurses, PCAs, aides, what have you, people are working at the bedside with patients. I've gained so much respect for those people, and I understand how hard it is for them to do what they do. So imagine all this craziness going on around you, and these devices that these people are carrying. It doesn't matter whose device. Some of them are great, some of them are better than others. It doesn't matter. These people are being challenged every day by all of that. So, as some of you read in the conference lead up, I'm going to talk to you about trying to tame the monster, because it is a monster. And if I could do it, I'd have the Godzilla shooting kind of the laser stuff out of his eyes. So for the last 15 years or so, I've been doing the work that Jim was talking about. I've been all about messaging. And I've been helping customers do more things with messaging. And my background ultimately starts with patient call systems. And no matter what we in the industry like to call them, if you talk to a nurse, they're going to refer to it as a call bell. So I've been there. And I've been there in the guise of lots of different companies. So those of you who have been around and know messaging systems know Emergent. So that's actually from a real Emergent implementation. So I showed up with my Emergent t-shirt. Then I showed up with my ASCOM t-shirt. That's actual ASCOM implementation. And then I showed up with my Vocera t-shirt on, right? And at each time I'm telling you, I have the best technology here to get the messages to the right people at the right time. More messages, better messages, right? And then I came with my Roland Borg shirt on, and I have my fancy Responder 5. You don't need middleware. You got this direct connect stuff. It's fantastic. And of course, I've showed up with my ConnectAll t-shirt on. And not only can I connect one thing, I can connect it all, and I can send it to you. And you know what? You know what it ends up being like? It ends up being like that. So part of my business still involves integration work for the customers. And as a result, Customers will come to me on a day-to-day basis and say, hey, I have new Massimo technology, and I want to now send it to my Vocera badges. Or I want to send epic notifications on new admits. And every day, there's more stuff. And at a plumbing technology level, any of us in the business can easily do any of those things for you. And we can do them rapidly, and we could do them with finesse, and we could do it the best way possible. But we're not necessarily thinking about it in the bigger picture. And you know what it ends up looking like to the nurse? It ends up being like that. If you've spent any time on a nursing unit, you begin to understand how hard it is for these people, but the literal noise from these systems, whether it be on mobile devices or the actual source systems, is intense, and it's consistent and persistent. And it doesn't matter what time of day it is. It could be in the morning, it could be in the middle of the night. Bed exit notification, patient gets out of bed, it's 3 o'clock in the morning, they go to the toilet and pull the cord, everybody's trying to sleep. And all these mobile devices are going off, and the console is going off, and it becomes very, very difficult for those people to concentrate on doing their work and doing their work effectively. The spectrum of things that my organization mostly deals with medical devices on one side, patient response devices on the other. It encompasses other things as well, but in general, this represents a spectrum. But the important thing about this arc is that some of those notifications are indeed inconvenient. They're important to know about, but they're not essential. They're not the same as a cardiac arrest or a death warning, if you will. And the systems that are in place today are capable, when configured properly in coordination between the critical parties, to modulate all of that. But rarely is it done. And I discovered that by watching the data flows of these systems across all of these different platforms. So just for fun, I had one of my team members visit one of our customers last week, and I said, Greg, can you do me a favor? Can you record some things from a particular unit? So I won't spend too much time on this, but I want to give you a feel of what this is like. So that's a regular old-fashioned nurse call. And tied to one of these messaging systems, it's going to trigger notification like that.
610 band call.
And then you could have multiple ones of these going off at the same time. So in a room, you might have a chair paired device, and it might be doing something like that.
Please don't get up. Sit back down and use the call button.
And at the same time, it's going to send a notification to the nurse call console, and then it's going to notify a bunch of different devices. And then let's throw into the let's throw into the mix a pager notification. And if it's a telemetry unit, you might have an assist lead. And there's an SMS message, a phone call, and here's a little bit of overhead page. I won't leave this playing for too long. You get the idea. So I have the great benefit of working with some very vocal customers. Craig, who is at Northern Westchester Hospital, is Vice President of Measurement, and I met him early on in our integration process. And at first I was nervous about him because he was really suspicious. He's saying, because what began to happen is he began to uncover some of the limitations of the technology that was ultimately sold to him. So in our work together with him, he and another woman who was part of the team at the time, Sue Etkin, we had a meeting one day, and they raised the point. They said, you know, we've just spent all this money on this patient redesign, had consultants in, they upgraded their wireless network, they deployed multiple house-wide voice over Wi-Fi devices, they did the integration to their nurse call system, and they said, this is actually helping us in taking care of patients. Now, at the time, their primary focus focus was patient experience. So it wasn't so much about medical alarms. But they started to ask that question. Let me introduce you to another one of my customers. This is Kelly Jones. She's manager of informatics at Stanford Hospital. And so one of the things that Kelly has said to me recently is that, and this is pretty obvious for any of us who work in the field, that we really kind of want to be at nurse call zero, right? Because if we have no nurse calls, or very few of them, it means that we're attending to the patient before they ask us. The bigger point is, so ironically, we're here at a messaging conference where we would be talking about getting messages to people. What she's telling us here, and what Greg is telling us, is we don't need more messages. We need better messages, smarter messages, and in many cases, less messages. So I'm going to step out of my presentation for a second, and I'm going to bring us to some measurement that we've been doing. So what we've been trying to do is to look at all these inputs and outputs, right? So somebody who's a caregiver who has a voice over Wi-Fi device, they're receiving calls, they may be making calls, right? Every time they're in that interaction, they're actually not communicating with a patient. They're not interacting with that patient directly. They're doing something else, which is often keeping them away from the work that they're trying to accomplish. And furthermore, there's nurse call activity. So we're trying to kind of put all this together with the idea that you could understand at any given time what the load is, right? Remember when I started, I said, what is your load? The idea being that the organization could look at these messaging streams, manage them, and look at them in real time, and begin to make adjustments to get that number down, right? So a distraction, according to this measurement paradigm, is a voice call that's going outbound, a voice call that might be going inbound, a nurse call that is being responded to or not. And this happens to be wrapping around some Vocera installation, so a broadcast, so where there's a one-to-many notification voice type of call. And what I'm suggesting here, regardless of the messaging stream, this happens to be around these messaging streams. Now this organization is able to look at the load as it relates to the roles of the individuals in the organization, and specifically look at it by time of day, normalized in such a way to understand, am I at risk? And do I have opportunities to lower those notification loads for those caregivers? What can I do to improve my patient care? How can this impact patient satisfaction? And then ultimately, as well, how can it improve staff satisfaction? So these are real numbers for last month of October, for a community hospital that has approximately 250 beds, and those numbers are pretty high, higher than I would imagine. So just kind of giving you a sense of what that traffic is like. And I'm going to just scroll down a little bit and show you how that looks during the course of the day. So the yellow arc those are outbound calls. The red arc are inbound calls. They're broadcast and nurse calls in the mix. So you can see that at noon at this organization, it's a pretty peak load, right? There's a lot of stuff going on. I would say this, at this point, we're still in a place of asking the questions. I'm going to suggest some remediation and solutions to all of this. But the first place, and several people have mentioned this, and you have to start looking at and understanding what it really is. And until you measure, you don't know. It's just anecdotal. And I'll just quickly show you one other example of that. So this is by the days of the month. And we had a little bit of glitch in our measurement, so after the 23rd, the nurse call drops off in the measurement. But it can give you a sense of the peaks and valleys. Obviously, some of those are weekends, probably instances of low census. But the idea is this organization not only can notify, they can look at those notification streams and begin to make decisions about it. Oops.
My name is Ernest Easter. I'm 31 years old. I live in
So there's been a lot of research shared. I don't want to spend a lot of time on the research, but I want to share a few notes. So we've talked a lot about alarms, and some people have talked about interruptions. I'm going to talk first about interruptions. So we all know that if we're in the middle of doing something, especially of high concentration, when interrupted, there's a high likelihood of us making some sort of error. And that error is ultimately quantifiable from a financial standpoint. So not only is this alarm notification fatigue annoying, it is risky and it's impeding our ability to perform well. An example here, so nurses carrying out documentation, they're interrupted, and they may end up putting the wrong documentation for the wrong patient. And there's a lot of examples of this in the literature. A lot of it's common sense. But it's clearly going on. Medication administration is an area that can be really impacted by notifications and disruptions, and I'm going to show some strategies about how some organizations are dealing with that. This echoes some of what Jim talked about. So there's a lot of nuisance alarms. There's a lot of disruption in the patient care areas. And when you ask the caregivers, and I think that's the most important nugget for me about this slide, when all of these things are going off and you're at peak in terms of the work that you need to do, it becomes very difficult to understand and carefully do what you need to do next. I'm going to start moving towards the end of the presentation, and I want to give a super duper concrete example of the problem in action. So I'm going to talk about falls and bed exit alarms. And for those of you who are not in a hospital on a day-to-day basis, well, there are devices that are hooked up to beds. Sometimes they're very sophisticated, but the very sophisticated ones are really expensive. So many hospitals, and I'll show you an example of it, end up having to use lower tech iterations of all that. So falls are really expensive to hospitals, and as a result, hospitals have gotten really paranoid about falls. So what they do when they do these alarm integration notification messaging projects, they start notifying a lot, and sometimes to multiple people. And I'm going to show you a concrete example of what that workflow ends up looking like. So that's a real bed, and that bed is not a super duper smart new bed with sophisticated technology. That's really just a pressure sensor. In this case, that pressure sensor is in the chair, but that same pressure sensor might be used in the bed. And I played this before, I'll just play it again. This is what this sounds
They
like.
hit the call button to call for help.
Enough of that. So in the case where the bed is actually hooked up to these lower tech notification capabilities. You have it literally hooked into the nurse call station, like you see up there. So, back to our kind of sample organization. They had 144 unique beds or chairs that sent notifications. They were sent to 159 unique nurses, 85 unique PCAs, and that was for the entire month of October. Let's just guess about the bed exit alarms. How many bed exit alarms do you think they had? Somebody hazard to guess? Throw out a number, somebody.
50.
2,000.
All right. Let's see what the real number was. So during the month of October, there were 6,458 bed exits for 144 unique beds. The number I want you to look at is the number next to it. It notified 28,707 times, right? Those were 28,707 unique messages that went to unique people, right? If you do the math, it comes out to, for every bed exit, there were 4.4 notifications, right? And I played you some of those notifications, and they were pretty loud. So, and some of the other presenters alluded to some of this. 20% of those bed exits resolved themselves within 3 seconds. No action required at all. So they could decide to not make any notification for 3 seconds, and they could reduce that alarm count very significantly. And if they were being really super conservative, they could say, hey, we're not going to notify anybody for 2 seconds, and they would reduce the alarms by 15.5%. So the point being here that organizations are in the position to look at this type of activity, and they're in the position to understand the impact that it has on their caregivers, and they're in the position to use the technology that they already have in place to make modifications either at the source device in the messaging systems that are talked about, and they're in the position to train their staff to do something about it. But it's important to start at a place of understanding what's actually going on. So what are the top 10 things that we can do? Anybody who's been working on this knows about the Joint Commission's recommendations about alarms, alarm management, alarm fatigue. It's been a top national patient safety goal for a long time. The alarm committees themselves tend to be focused primarily on medical devices. My suggestion is that this is a bigger thing, and those committees or those initiatives need to be inclusive. There are many workflows that involve notification that are putting out spurious notifications, and the people receiving them are not empowered to do anything about them. So we are in a position, especially if we measure and report on this, to be able to prioritize and eliminate when possible. Notification alarm thresholds can be set as KPIs. So that 4.4 number, that could be a no-no. The organization could say, hey, we're going to keep this under 4, and that's an important goal for us. And let's do what's necessary in order to do that. Obviously, I'm in the reporting business, but there are many other quality providers who can provide that information. It can also be homegrown. But the point is that organizations are in the position to look across these systems and look at the information that's being shared by them and look at them in a cohesive way. And this whole suspend scenario, so an apnea alarm that's self-correcting doesn't need to notify. A bed exit alarm that gets corrected in 2 seconds doesn't need to notify it. All those things can be put together. educating your staff is really, really critical. Most people don't realize that something can be done about these things. So the number 7, I think, is really important, surveying staff and understanding and empowering them to say, hey, why am I getting this? I find that most people just get annoyed and they aren't empowered to do anything about it. You'll notice the Do Not Disturb drug round in progress bib. You can buy that on Etsy. The idea being that somebody wearing that bib won't be disturbed or notified when they're doing drug administration. I'm going to show you a picture of a no interruption zone. That would be a place that needs concentration, and perhaps the phone could be smart enough to be silenced in that arena. And then the last one, modifying and tweaking the source systems. That's obviously how you ultimately solve the problem in a bigger way. And so here's the med notification zone at Northern Westchester Hospital. And when you're in that zone, you should not be bothered. So thanks for joining me on my little journey here. The larger point, you'll notice I'm not wearing dark glasses in this, is that organizations, their vendor collaborators, technology providers, we are all in a position to actually do something about the notification deluge, the alarm fatigue. And it starts with measurement in terms of understanding what is actually going on. It requires involving the staff members and understanding the impact of this. And it requires benchmarking and understanding where the organizations want to go. Should any of you want to contact me, my contact information is up there. Any questions? All right, well, thank you for your time and your attention.